for graduation, so that was really helpful. Thank you guys. We're working something from yesterday to see what you remember about peds neurology. At least lie to me. It's like, okay, what type of seizure do we treat with ethosuximide? Absence seizures, you guys are so good at those. Do them on 3. 1, 2, 3. I will never not think of those. Okay, a child has a febrile seizure. It happened once in 24 hours. It was a global seizure, and it lasted for 20 minutes. How do you characterize this febrile seizure?
Katasepi? About this?
It's a febrile seizure. So it's a febrile seizure. So I'm already giving you that classification. Okay. It is a febrile seizure. It's happened once in 24 hours. It's a global seizure, and it lasted for 20 minutes. How do you characterize this? Complex. Correct. Why is it a complex febrile seizure? More than 15 minutes. Correct. So you are right if it's over that 5-minute mark, but I've already given you that it's a febrile seizure. So we're already in that classification for it. Because now in children, how long is status epilepticus defined as? Yep, 5 minutes. What are the 4 electrolytes you need to check when you're thinking about seizures in any humans, but particularly children? Sodium. Glucose, sodium, calcium,
magnesium.
Correct. What is migraine with an aura a contraindication to give me?
OCPs.
OCPs. What kind of OCPs?
Estrogen.
Estrogen. Correct. Child has a concussion and has a seizure at the time of the event. The parents are completely freaked out and they ask you about the prognosis. What do you tell them as the provider? It's a good prognosis. This happens and they have a seizure 11 days out from injury. What do you tell the parents? Yeah, the prognosis is not as good. A child wakes up very upset at 5 a.m. and the mom can soothe the child back to sleep. Is this a nightmare or a night terror? Nightmare. What was the inheritance pattern of muscular dystrophy? Excellent. Yep. So what patient population is that always going to be then? Males, boys, little boys. Correct. Okay. So we're jumping back in to finish out peds neuro. So at the end of peds neuro, there's a whole subclassification of neurocutaneous disorders. What 2 systems are we talking about? Brain and skin. Why do those go together? Well, they're from the same embryologic derivative. So the ectoderm makes your brain and makes your skin. So while you're developing as an embryo, if something is going wrong with your ectoderm, it's going to mean that potentially both of those systems are affected together. So sometimes in embryology, timing matters. So remember we said the kidneys and what formed at the same time? Kidneys and the ear formed at the same time. So sometimes it's about timing and when something would hit, and sometimes it's about origin structure. So neurocutaneous disorders go with your structure of origin. Remember, I'm not going to test you on embryology of this, but it helps understand why they go together. So oftentimes, when children have a neurologic disorder, other things we look at are things in the dermatologic zone. We're looking at their hair, at their teeth, at their skin, to see if there is that correlation and it's a neurocutaneous disorder. We're going to talk about these 3, neurofibromatosis, tuberous sclerosis, and then Sturge-Weber's. We'll talk about all of those in detail. Neurofibromatosis 1, also called NF1, also used to be called von Recklinghausen disease. So if you see those, cancer's not going to use those. It's an old terminology you might see. This one's autosomal dominant, meaning how many parents do you need? 1 parent. If your parent has this, what is your percent chance that you are going to get it?
50.
50%. Yep. You either have it or you don't. You need 1 parent, 50%. Have it or you don't. The gene for this is a gene for neurofibrin. And what neurofibrin does is it makes these neurofibers. Well, the problem is when this mutation happens, there's functionally like if you stopped at a train track and those arms come down to stop everything, what happens in this mutation is basically the arms go up. And so things just continue to get made. So this gene is then always on. You're always making this neurofibrin. That's what's happening in these Schwann cells. Most of the time, that's okay, and it's becoming mostly a cosmetic issue that we will see. Some of the time, it's not okay, depending on where this neurofibrin starts proliferating. We'll take a look at some of that. So things that we see for NF1. The first thing is a café-au-lait spot or a café-au-lait macule. What is the colloquial term for a café-au-lait macule? You see it in a baby. Yeah, a birthmark. You're like, oh, this is just one of those birthmarks. Like people come out and they're like, my birthmark looks like Tennessee. And you're like, sure, right? So totally normal. We see those all the time. What happens is when we see a plethora of those. So that's thing one. So these café-au-lait macules, most of the time, 90%. The second thing is really interesting. So your homework tonight that I need you to go do, I need you to go to the mirror, lift up your armpits, and check to see if you have axillary freckling. Most people don't have freckles under their armpits. Okay? That's an area where you don't see that. Same in the groin. And you don't see inguinal freckling. There was a patient, so I tell you this because it's very rare, and when you see it, you're like, I know what that is. It's the syndrome called Legius syndrome and NF1. One of my last stations was at the gym with a friend of mine. That was also their child's PCO, very small base. And we were working out, and I look and I'm like, this lady has axillary freckling. And anyway, once I saw her kid had axillary freckling, had Legius syndrome. So you're like, that's a really unique physical exam finding. So go home tonight, look at your armpits. Look at your wife, your husband, your kids, look at their armpits. See if they have axillary freckling. You have cutaneous neurofibromas, so that's what this picture is at the bottom, where you see that that's what they are, those neurofibromas that have popped up. They can pop up anywhere, and that's really oftentimes what the cosmetic outcome ends up being that people don't like. And then, obviously, these iris hamartomas, or these Lish nodules. So that's an example at the tippity top, that picture of the eye. And those are ones that I don't see. You guys might see these because they develop over time, and so you really don't see them into adulthood. So you see that probably going to be a later presentation. So in the pediatric population, you're going to be mostly looking for this café-au-lait macules and your axillary freckling. You need 2 or more of those, right? So we just said we're looking for the café-au-lait macules, but you need specific numbers of this. So it's not just like you have the birthmark, it's Tennessee, you have NF1, you need to have at least 6 of them. They need to be more than half a centimeter. So they have to be decent size, and they have to be fairly sizable in numbers. So this is when you're looking at a baby and you see 1, you're like, okay. You see 2, okay. If you see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, that's usually what that's going to present like. More than 6 that are 5 millimeters or more, the freckling. If you see the Lish nodules or the neurofibromas, there's also some other more aggressive ones like an optic glioma. So if you had a white reflex and you sent somebody to ophthalmology and some scans came back with an optic glioma, that could be one of the diagnostic signs as well as some of your osseous lesions. Or one of the diagnostic criteria is that a family has NF1. So let's think about a scenario where a child comes in, 9-month-old child comes in for a cold. You're seeing them for a cold, you're taking a family history. Mom says, I have NF1. Okay, put that down in your history. You do your physical exam of the baby, 1, 2, 3, 4, 5, 6, 7, 8, 9. So I have 9 café-au-lait macules and a first-degree relative. Well, I'm diagnosing you today with a URI and NF1. Okay? You can walk out of there with a clinical diagnosis of NF1, neurocutaneous. Some of these complications then become where those neurofibromas are. So if they're on the outside of the skin, cosmetic complication. If they're up in the brain, on the spinal cord, much bigger of a problem. And that's when it becomes a variable outcome of how much function, how many seizures, what kind of cerebral vascular normal or abnormality do they have. Where are the other tumors located? It can be anywhere along the CNS, so you can see that as a presentation. Neuro is going to be on board, and ophthalmology is going to be on board. First to see, do we have Lisch nodules? And then, are we having any of these optic tumors? So those two specialties, and they will do several different types of scans to see, do we have any kind of CNS tumors going on? So they will do that. So your biggest thing is, can I identify this is a neurocutaneous disorder? Do I know the diagnostic criteria, and can I get them to the specialists? There's a type 1, that implies that there's a type 2. In fact, there is. So there's neurofibromatosis type 2, NF2. Much more rare. So we see this in a whole lot less children. It's an autosomal active duty, and autosomal dominant. So again, one parent, 50% chance, different mutation this time. And this one codes for Merlin instead of neurofibrin. So it sounds like we're in Harry Potter land or something. We're like, Merlin, let's turn on. And this one, the biggest one that I want you to see for buzzwords, because this is just one that we don't see as often clinically, but if you ever do a scan and you see bilateral acoustic schwannoma. Acoustic schwannomas are NF2 until proven otherwise. They typically, that's where you're going to see more likely that they have these CNS tumors, and that's very specific. The one in the ear, very, very specific for a NF2. They also will have some of your skin lesion and some of the eye findings with some of the cataracts. They don't have your classic catheolae macules and your axillary. So the two things that you're like, that's what I'm going to remember for pediatric NF1, NF2 doesn't have. So big difference there in the way that these kiddos are going to present. What I don't need you to do, I don't need you to spend time with your diagnostic criteria for NF2. The point of this slide is to remind you that they're different criteria. They are fundamentally different diseases. This one is so rare, though, that this is one that you will look up. So if you start seeing kids and something doesn't make sense, or an adult that has some of these findings as well, you're going to look up this criteria. You're not going to memorize it for this exam. And PANCE really looks at more of the history of that, not your diagnostic criteria. Let's take this NF1. So our second neurocutaneous disorder, again derived from that ectoderm, brain and skin together, is going to be tuberous sclerosis. Again, we're autosomal dominant, one parent, 50%. This one, though, has a lot of sporadic mutations. So this is one where we could have no family history and it's just popping up. Pretty common for that to happen with this one. The thing about tuberous sclerosis, I will say, I've seen it a couple times in real life, but I see it all over the board because there are such specific things. So it is an easy testing fodder because you don't see a lot of these specific findings in anything else. This time you have hamartomas, so they are benign, so they're much like tubers, but they're slightly, well, you see those two, but they're different than the neurofibromas. So you see these everywhere. I'm not going to ask you the specific mutations of the specific genes. That's a little bit beyond where we are, but just to know, hey, these are on specific chromosomes and these are specific genes related to this. And the problem with this is that this preferentially also likes to go to the brain. And when it does, it takes up so much room that you end up with seizures and even potentially infantile spasms. So a whole different subset, similar to a seizure, much, much worse. Because the brain is truly having, and the body is spasming that. Depending on where and how many hamartomas you are seeing, you have a completely, extremely variable presentation. So you could have two children that both have tuberous sclerosis that look entirely different. So a wide, wide clinical variability without this. They might have normal intelligence all the way to refractory seizures and barely able to communicate. Anywhere in between with that. A lot of variation of that. So one of the things, we're going to kind of build on all of these features. One of the features that you see is adenoma sebaceum. You're like, what is that? So it is an angiofibroma. So angio meaning it's of the blood vessel. You have blood vessel benign tumors that create kind of a half rash, half acne looking presentation, but it's really inside the blood vessels. So if you're starting to see that on a child who shouldn't have hit puberty yet, concerning. So what age would that be for girls?
9.
Less than 8, correct? And boys less than 9, right? So you have a 6-year-old coming in with this horrendous acne. You're thinking to yourself, ooh, on my differential is now precocious puberty, or is this a presentation of tuberous sclerosis? And this is actually adenoma sebaceum. Some intellectual disability also can come with this, and then again with the epilepsy. Okay, that was some of the skin manifestations. What else for the CNS? So now we just have these tubers. So that's how it gets its name, tuberous sclerosis. You look, and we'll look at a couple of scans. It truly looks like when you have a potato and it starts growing the little tubers off of it. That's what the scan looks like. That's what, when you see that, that's what it's looking like. That's what's going to be causing some of the seizures, spasms, and some of the intellectual disability with that. Other skin manifestations. So we said, yep, we got adenoma sebaceum. The Ashley spots. What this looks like, the best description that I have. Do we have any 80s and 90s babies in here? Okay. When we were all in high school, do you remember the days where you would, well, if you were a female, or maybe male, I don't know, but you would take one of those little stickers and you would put a sticker and then you would tan and then you would take the sticker off and so you had a little heart of this not tan spot? I know you guys are very familiar with this. That's what an Ashley spot looks like. It looks like one area that didn't tan around everything else. That's exactly what an Ashley spot looks like. It's macular, hypopigmented, and it's very sharply demarcated. Okay? A chagrin patch almost looks the exact opposite. It is a raised plaque, and it is slightly hyperpigmented usually because it is got a little bit of erythema, a little bit of redness, hyper pigmented, a little bit of area. Typically we'll see somewhere in the back. It can be anywhere, but you see those kind of manifestations. What will kill people from tuberous sclerosis though is when renal is involved. So renal manifestations can become malignant manifestations, and over time that's functionally what the adults usually succumb from. So it's not what we see in the kids usually, but eventually as adults it's the renal switch into a malignant tumor that is so this is what a couple of things that we're looking at. So if you're looking at the scan, you're looking inside the ventricles, that's what those little tubers are. So it looks like a potato that you have those tubers coming out in. Not normal. Not normal to have these little tubers inside the ventricles. This is that chagrin patch, so it's raised, rough, elevated, typically on the back, and then that Ashley hypopigmented spot. Think late 1990s tanning. There's a lot of pictures of this, and this is one that they love to test it. So you can have the Ashley spot. This is what the adenoma sebaceum looks like. So you can see how if somebody's coming in, you're thinking, oh, this is acne, or oh, is this a presentation of lupus? Oh, is this a presentation of fill in the blank? There's a whole lot of things. But if you have something where acne doesn't make sense, they're too young, they're not responding to any of your acne treatments, you have to think to yourself, maybe it's not acne, maybe it's adenoma sebaceum. Another chagrin patch, and then what these are looking at, so these are tubers inside on the optic nerve as well. So you can get those tubers anywhere, and those are what can be part of the problem with this. More pictures, because there's a lot of them. So tubers, see the tubers, adenoma sebaceum, the kidney manifestation, tubers in the lung, or tubers in the heart, tubers in the eyes, all kinds of things. So this is one, again, not one that you see a lot in clinic, but easy testing fodder because it looks like a lot of other things. It looks like acne. It looks like vitiligo. It looks like intellectual disability. It looks like a lot of stuff. So you start seeing it put together, you're like, it's got to be tuberous sclerosis. I am not going to ask you to memorize the Diagnostic criteria, again, that's a little outside of our realm here, just to show you that it all has these diagnostic criteria. So when you start thinking, man, these are all a bunch of weird findings put together, you need to go and look up that diagnostic criteria. So what I do want you to know is the criteria for NF1. I'm not going to ask you NF2 or tuberous sclerosis for that. What would you be responsible for as a PA? So one of the things that we're thinking, remember what two organ systems we were looking at? Brain and skin. So those are the two things we're looking at. We're scanning and we're taking a biopsy. You need to look at your CNS, you need to look at the skin. So neurology and dermatology are two friends that we consult for those once we have appropriate scans and workup. They will help with seizure medications, they will help with any dermatologic outcomes. There's really a lot of surveillance for these kids because they often need a whole lot of help developmentally from a school perspective and an educational perspective. The prognosis really depends on where those tubers are. So do they have some of the benign tubers that aren't causing a problem? They're doing okay. If they have that severe intellectual disability and they have refractory seizures, that's certainly a different set of problems. Do any of those tubers become malignant? So if you get the angiofibromas that become malignant, suddenly, again, that's going to be a different set of problems. And that renal ones are, again, what usually they succumb to in adulthood. And last but not least, we are into Sturge-Weber syndrome. This is such an interesting pathology to me. It blows my mind because this doesn't fit anything that we've learned before. So this is not inherited at all. It's not from mom, it's not from dad, it's not from anything. This is totally sporadic inheritance. That's wild, right? That's why we're like, can we pin this down to any genetic cause? You're like, nope, totally sporadic. So sporadic inheritance, that's number one that's weird. Thing two is that it's ipsilateral to the brain. Most things with neuro are contralateral. Something happens on one side, you see it manifest on the other side. Most things when you're thinking about neuro are like that. Sturge-Weber is not. It is ipsilateral. So you see issues with the leptomeningeal blood vessels. You think to yourself, leptomeningeal, I don't remember where that is. Let's talk about that. It's the two most inner linings of your meninges. So between your arachnoid and your pia mater is where you have your leptomeningeal blood vessels. Those can have these manifestations where they are abnormal. You end up with these abnormal, non-functioning blood vessels as half of your brain. Means you have these abnormal, kind of non-functioning blood vessels everywhere else on that side as well. So we talked about this from block 1. If you can remember way back in block 1, we have the nevius flammis, or the port wine stain. It was called port wine stain because it looks like that dark red wine that you would pour on the face would leave that stain just on that half. It also means that that half of the face has the eye. So ophthalmology is involved in this as well. Those blood vessels are not normal and they are not functionally normal. And you don't have normal drainage of the eye, you end up with high pressures in the eye and infantile glaucoma. So glaucoma is your no miss. So highlight, underline, star that one. This is your no miss here. You cannot miss the infantile glaucoma when you see this. So you see the port wine stain, you have to think, oh, the wine got in the baby's eye, I need to get them to ophthalmology for the glaucoma. The thing about this is the seizures also. So the seizures are from that ischemic part where the blood vessels are abnormal and they're not having normal blood flow. And these seizures are often so bad, so refractory, that it really does take a significant toll on these patients' lives. So they can have stroke-like symptoms almost, they can have complete hemiparesia of one side of their body, significant intellectual disability, and refractive seizures. So not difficult outcome. If you're looking at a scan of this brain, you're thinking to yourself, wow, that half doesn't look normal. And that's exactly what's happening. It did not get the correct flow. And as we've said, no flow equals no grow. It did not grow correctly. That is right. So your friends that you're getting them to, your nevus flammeus, they are going to go over to derm for some laser procedures, possibly. For your seizures, you're sending them over to neurology to help manage with anticonvulsants. For your glaucoma, or infantile glaucoma, you're sending them over to the pediatric ophthalmologist, and potentially over into peds neurosurgery as well. Some of these children, their seizures are so refractory, they end up needing a hemispherectomy because that side of the brain is so abnormal developed. Okay? So what is the inheritance pattern for tuberous sclerosis? Autosomal dominant. What is it for NF1? Autosomal dominant. What is it for Sturge-Weber? Sporadic. What is it for NF2? Dominant. What is it for muscular dystrophy? Excellent. Okay? Perfect. You guys got it. So patterns of that, who we need to get to, and why neurocutaneous go together. Or Sturge-Weber. That was neuro. We did it. One down. We are on to cardiology. What is your homework tonight? Look at your armpits. Yep. That is your homework tonight. Okay. So as much as I didn't like neurology, I love cardiology. We're back to loving it. So get excited. We're going to do some cardiology dances together with this. So peds cardiology, again, not a rehash of what Dr. DeBoer taught you. There is no way to compete with how that man teaches. He is just phenomenal. So I hope that you are able to soak in all of that. A lot of what we're doing with peds cardiology is things that you saw, maybe a little bit deeper. We'll go into some of this. And as a reminder, so some of this should feel like, I got this. I knew this from Dr. DeBoer. Okay, so our circulation review. What is connecting in utero? What is connecting your two atrium together? Your foraminovalle, correct. And which way, what direction of flow is the blood going from? Right to left. What are you bypassing? Your ventricles, which is bypassing what? The lungs. Okay, so your foraminovalle, you're bypassing the lungs because you don't need it, because what's oxygenating the blood for this baby? Mom, the placenta, correct. Okay, so you're bypassing the lungs. A little bit is going to go down into that right ventricle, and you're going to go out the pulmonary artery, and you're still going to bypass the lungs. It's going from the pulmonary artery out to the aorta. What is that called? Without the P part. Just the DA, the ductus arteriosus. Okay? So ductus arteriosus is bypassing the lungs from that little bit that did go down into the ventricle, that didn't go across the foraminovalle. Okay? Let's say you're coming back. You've gone through and you're going to bypass the liver. What are you going to take to bypass the liver? The vena cava. Yeah, the ductus venosus is what you're going to do. So at foraminovalle, you're going to bypass the lungs by going from the right atrium directly to the right, or to the right, right atrium to the right atrium to the left atrium. The ductus arteriosus, the pulmonary artery, bypassing the lungs out to the aorta directly. And then the ductus venosus is bypassing the liver. So those two organs get bypassed all of your fetal time, right? You bypass the lungs, you bypass the liver. So that makes sense when babies come out. What two organs do they really, really struggle with? Your lungs and your liver. Right? Because they didn't get worked. The placenta was oxygenating, the placenta was detoxified. So that should make sense then why you see things like hyperbilirubinemia, TTN, all of those things that we talked about in block 1. You're getting bypassed here. A reminder, the foraminovalle, so when it's going from right to left, it has a kind of one-way door that allows it to open that way. Baby takes its first breath, pressure should change, that should close it. When it doesn't close, that becomes your PFO, patent foraminovalle, right? That doesn't close. So as a reminder, that's what fetal circulation is looking like. You have those three places that bypass the two organs. They're called the ductus and the venosus. And then, 1, 2, 3. Then they take first breath. We go into neonatal circulation. We should no longer have a foramen-ovale. It should just be nothing, right? If it stays open, it's the PFO, the patent foramen-ovale. You should no longer then have a DA, a ductus arteriosus. If it stays open, it's now a PDA. If it closes correctly, it's a ligamentous arteriosus. So it's now just this little remnant of a ligament. And you should no longer have a ductus venosus as well. And you should have a ligamentum venosus. So all of those things should just close right up in neonatal circulation. So things that happen with infants. So now they have these congenital, ones that do have congenital heart defects, they might not be present on your very first exam. You might think, okay, baby just delivered, I did my heart exam, I didn't hear anything. And it's because that switch from neonatal, or from prenatal to neonatal circulation is not instant. Right? A lot happens at that first breath, but it's not completely instant. And so for those things, it will often take some time for all of your pressures to equalize and to see really where you are. It may present instead with the baby having some secondary symptoms. What does that look like? Well, babies don't do a whole lot of exercise. They're not going out and preparing for half marathons or anything. A baby's exercise is what? Eating, right? So if a baby looks like they're having a significantly hard time eating in the form of excessive sweating, like they look like they're having night sweats after they're feeding, or they're feeding and then incredibly fussy after. One of the differentials then is, well, are they having colic? Do they have GERD? Or do they have a congenital heart lesion? And you're asking their body to produce more and give more oxygen to digest than they have available. So extreme fussiness after feeding or sweating with feeds should make you think, if you see that on a test question, that's a buzzword for a congenital cardiac lesion. The other thing would be failure to thrive. You need oxygen to be able to grow. You don't have that growth, you don't have that luxury of growth then. I say this, I'll tell you a story when we get to it. For the older children, you should be doing cardiac exams in multiple positions. You can hear physiology really well for children. So if they're going from sitting, standing, to laying, you can hear a lot of different types of heart sounds there. Those same things that you learned for the adults, the murmurs, rubs, growls, clicks, you see in children as well. The one thing I will say, and just a plug for when you're typing your notes someday, is you might get a really high heart rate or a low heart rate, and in your exam people will be like, regular rate and rhythm. You're like, well, it's not. It's tachycardic. It's not a regular rate. Or it's bradycardic. It's not a regular rate. It should be a regular rhythm, not a regular rate. Other things that you're looking at for kids, do they have too much of excessive circulation? So are their lungs being flooded and you're hearing that as crackles, or they're trying to have tachypnea to move things out? JVD is pretty rare for a child. There would be something really backed up from the liver. You'd be seeing a lot of pressure there, but certainly things that you see. Your skin and nails have the same exact ones as adults, sometimes a little bit harder to see with the little baby hands. So if you've worked with me and seen me in Clencor, a lot of times they'll say, don't do capillary refill where you're doing this for the teeny tiny little baby nails. Use their whole hand, use the back of their hand to really get a capillary refill to see if you're seeing moving in and out of those capillaries. For your abdomen, the liver is going to end up inferior if it's filled with blood, and then certainly if they have endocarditis, you're going to see that with spleen. With which type of bacteria? The spleen particularly will pull out what type of bacteria?
Staph.
I'll give you a hint, it's got capsules around it. Encapsulated bacteria. What are your encapsulated bacteria?
It's triple.
Oh boy.
Come on, block one, you can do it. Encapsulated bacteria. Which bacteria have the capsules around them? Neisseria.
Horse influenza.
Klebsiella. Correct. Two more. Strep pneumo. And pip.
I don't think you're.
I tested you on this in block one. I know you guys will learn this. I know you guys will learn this. Okay? You'll need this for hemong when we get here later in the week. So, encapsulated bacteria that this week takes up. Are you all okay? Oh, okay.
I thought I took EEG.
I convinced you guys yesterday you took an EEG class. I did. That was me.
Really easy to gaslight.
It is true. Yeah. The heart sounds S1 and S2, your different valves closing. So you have S1, the beginning, where you have your valves between your atrium and your ventricles. S2, you have your aortic and your pulmonary valves closing to the lungs and to the body. So a reminder, if you ever see fixed split S2, that has to be ASC. We'll talk about that again when we get to that one. S3 can be normal in kids, so that is one of the differences between a child and an adult. S3 in a child could mean you're literally hearing the physiology of the compliant heart filling and the chordae tympanae. Or it could be a pathologic sound that you're hearing the heart inappropriately fill because things are not normal. So normal variant for the most part in children. S4, abnormal for everybody. You're hearing that? Not okay. Abnormal for S4, abnormal for everybody. Clicks, same as adults. You've already learned those. And then your murmurs. When we're talking about 1 through 4, where is the defining one? Or what's the defining thing between 1, 2, and 3, 4, 5, and 6? A thrill at 4. So what does that mean is actually happening? That means 2 of your senses are involved. So you are hearing it and you are feeling it, feeling, F-E-E-L, feeling it at that 4. Holosystolic is going to mean that you aren't hearing that, all of systole, you see that. Obviously it's going to give you an area, you're going to see how intense it is, what does it sound like, that matters a lot for pediatrics. So when we get to that one, I'll tell you, if they sound like nice words, they're benign. So if you hear things like, it's musical, it's a whimsical murmur, you're like, this is totally benign. If you're like, this is harsh, this sounds bad, you're like, oh, it's pathologic, right? So pediatrics use the words correctly. So musical murmurs, fine. Harsh murmurs, bad. And then does it change with position? So when you get to your rotations, just a hint, it's up to you. If you have the best ears ever and the Army and the Air Force has not messed with your ears over the years and you can hear a grade 1 murmur, you should be a cardiology PA. Just telling you now. It is almost impossible to hear a 1 out of 6 murmur. Okay? So on your rotations, unless you are absolutely sure, and in which case it's still probably a 2 or 3, don't say 1 out of 6, because you probably can't hear it. Right? Maybe you can, and if you can again, you should go into cardiology. Most murmurs that we hear are going to be 2 and 3. They are audible to the ear with a stethoscope, and you're either saying, ooh, do I barely hear it? And that's a 2, or is that pretty obvious? And that's a 3. What you start then, if you feel it on their chest, then a 4. If you feel it and you can almost see it, you start getting into 5 and 6. If you're the person that's seeing a 5 or a 6 and no one else knows about this, you should go get somebody who also knows about this. Okay? Just especially for your rotations, because a 5 or a 6 tells you something is not normal, or something at all, and in no way, shape, or form is this normal. Things that you can do for cardiac testing. So if you think something is wrong with the heart, we always want to get a baseline chest x-ray for a couple of reasons. Is the anatomy situated normally? There was one time where I went to go listen to a child and I was like, that doesn't sound right, like at all. I don't know what that sounds like, but it's not normal, right? Got a chest x-ray, it has dextrocardia. And you're like, well, that will do it, right? Wrong side, let's try the other side, listen. So it can give you some general anatomy, some general size, some general indication of where the arches are, if there's cardiomegaly or not, so that can be helpful. And then a baseline ECG. So you're looking for some of these basic rhythms that we'll go through and we'll talk about as a reminder. If they're advanced, that's when pediatric cardiology will help us out. The reason I say that even more so than the adult heart is if you have an adult heart, you knew that it had normal anatomy to get to the point where there's an adult finding, and now it's starting to have pretty predictable patterns. If the child's heart didn't form normally, and so you have abnormal anatomy, well then the electricity is going to be very off as well, and so oftentimes you need the help of the pediatric cardiologist to read some of these. So, abnormal hearts especially. Difference here again between peds and adults. If you have the need for a pediatric echo, you need to refer them also to a cardiologist. So for the adult world, you can send that off, you get the results, you press on, all is well. If you're saying I do need an echo, then they need to be seeing the cardiologist as well. And then again, definitive test would be a cardiac cath. It is therapeutic and can be diagnostic and therapeutic, pretty invasive. We don't do as much of those in the peds world. When we get to some of the murmurs, okay, so this is where we get to nice words and mean words. Okay, so if I say something is functional, that means just like we did for GI, it means their anatomy is normal. And in this case, for cardiology, their physiology is normal as well. So just like we said, let's way back it up. We said a seizure is just uncontrolled electrical activity. So what's a murmur? Just at its baseline, what's a murmur?
Sound like
The sound of
the defect.
blood flow. You're like, I'm just hearing the sound of the flow, right? We've now associated it with grandma's in the hospital, there's a new heart murmur, she's not doing well. So murmur has a negative connotation to it. But a murmur is just the sound of the flow of blood. So when you're hearing functional murmurs in children, you're just hearing their physiology. Functional means innocent, functional means benign. So if you see any of those words, totally normal, you're just hearing the physiology of a normal child. Things that we do here, we'll go through some of these. You can hear a venous hum. You are just hearing the blood returning from their brains. They have big giant heads, a lot of blood flow is returning. You are hearing that in the veins of their neck. Venous hum. A Stills murmur, you are hearing the compliance and the squeeze of that left ventricle. That's all you're hearing. It sounds musical. It sounds whimsical. Totally functional. You're hearing their normal, healthy heart. Pulmonary blood flow. Little babies, literally what it sounds like. If you hear it because their hearts are going so fast, it sounds musical. Little babies with a pulmonary blood flow. So if you think about their teeny tiny little lungs, and they're making these kind of sharp turns into the different lobes, you're hearing that blood kind of making a sharp turn. That's all it is. Pulmonary flow, right side. The ones that are pathologic, they are harsh. They are not normal, right? So these are your things that have stenosis or regurgitation with the valves. If you have an inappropriate hole, or if you have something that didn't close, those are not normal. Those are never going to be normal. I need you to know these, okay? So star this one for this. I need you to know these normal murmurs. The ones that I want you to be particularly familiar with are the Stills murmur, okay? This is a normal, so all of these are those functional murmurs. Normal murmur. So it's vibratory, it's musical, whimsical, right? All these happy sounding words. And those are the systolic murmur, systolic ejection murmur. That's that left ventricle squeezing, hearing the normal physiology of a toddler. So it's typically 3, 4, 5, 6 years old, well, before they start kindergarten, and you're hearing their normal healthy hearts. It can sometimes be pretty loud, but you hear everything else is completely normal. So you should be able to hear one of these on your rotation at least. Out of 20 kids, you're seeing kids all day, a couple of them will have it all the time. Your venous hum, you're coming back, you're hearing that in the neck or right below the clavicles. Again, that should be you're hearing it all the time. It's continuous because there's no valves. So you're just hearing this hum the whole time of the venous return. Don't worry, skip over the carotid brewery. And the other one is that peripheral pulmonary stenosis, where you see blood is going and it's switching directions very quickly. So you can hear those along the left upper sternal border and as well as in the axilla and then in the back, where you have a whole lot of blood flowing into the lungs. Makes some more sense that you hear that at a younger age when they're newborn, because that's when the teeny tiny vessels are still opening up and they're the smallest. These are those functional murmurs. So that top one, those blue arrows, are the venous hum that you're hearing. The red arrow is your Still's murmur, so it's going the direction of your left ventricle is going to send everything out your aorta. And then your branch pulmonary stenosis, again, left upper sternal border, and then into the axilla and the back. Things about the innocent murmurs, tell the families, please tell them, I hear a murmur. A murmur is just the sound of their healthy blood flowing. If you flushed your toilet, the example that I always give them is, if you flushed your toilet and you heard the flow of the water, does that mean your pipes are broken? Nope, it just means you're hearing the sound of the water. It's very similar to this. The worst thing that can happen, you don't tell them. You hear a loud 3 out of 6 murmur. It's musical, it's whimsical, and they then get a fever, as kids do. They go to the ER. The ER, what happens when children have fevers? To their heart rates. Goes up. What happens to their stroke volume? It goes up. So they have a lot of blood flowing and it's going pretty fast, right? And so now their cardiac output is higher. Sorry, their stroke volume is the same. Their cardiac output is higher because their heart rate is higher. And now all of a sudden someone goes and listens to that heart, you hear the Still's murmur, and they come back in the ER and they say, do you know your child has a heart murmur? Can you imagine how that goes over, right? Not well. So if you can, in the clinic visit, a well visit, any other time, say, hey, did you know that your child has a completely innocent heart murmur? It means they have a normal, healthy heart. Then when they hear that in the ER, did you know your child has a heart murmur? Yeah, we did. It's totally normal. It's innocent. Okay. We proceed on. So it's super helpful to discuss it with the parents. And before your souls leave your bodies, let's take a break, come back at the top of the hour. Smart, we're really kind providers, and this is really important to do. Okay, so on to chest pain. I just had to tell you guys that today. So, breathing and chest pain. Chest pain for kids. Do you think it's mostly cardiac or mostly not cardiac? Not cardiac, right? So if a kid comes in thinking, I have chest pain, it's probably not cardiac. The times the red flag ones are in red. So, do they have chest pain and they faint? More likely cardiac. Do they have chest pain while they're exerting themselves? More likely. It's still more likely that it's pulmonary at that point and like an asthma presentation, but you gotta do your workup. Are they having palpitations and chest pain? More likely cardiac. And acute onset with fever. More likely an infectious pericarditis or a myocarditis. So more likely cardiology. So those are your kind of your red flag questions to ask if they come in with chest pain. And that's otherwise, most of the time it's not that. So it's going to be everything else, and your exam is going to be mostly in what systems? Heart, lungs, musculoskeletal, derm, and GI. That's what you're really looking at. So your differential is long. Don't memorize this at all, right? This should tell you, oh my goodness, the things that I'm looking at for kid chest pain, it's probably going to be musculoskeletal, right? They're growing, they're developing, they're transforming right in front of you. Most of the time, musculoskeletal. Secondary, it's probably pulmonary. They're using that blood flow and oxygen exchange to grow. something with that is causing a problem. You get a little bit more with that anxiety, so some of those idiopathic or less common scenarios. And then you start getting down into the less common, but still more likely than cardiology, so GI. And finally, cardiology. So really, for chest pain, cardiac is the least common in pediatrics. Very, very different than in the adult world. If you have chest pain, things that are always okay to get, you're always okay to get an ECG or an EKG. That will save your behind as a provider. So when in doubt, even if you're like, that's not cardiac, it's still okay to get an EKG to make sure you have that baseline. There are times where parents and families and even other providers just associate chest pain with the heart, and I'm not going to be okay until I know the heart is okay. And sometimes that is an appropriate reason to refer to specialty care as well, is they need to have that secondary reassurance from a specialist. If that's the case, tell the consultant that, right? If you're just like, chest pain, refer to cardiology, the cardiologist, the peds cardiologist is going to be like, this provider's an idiot, right? If you're saying, ruled out from history and physical cardiac etiology, normal chest x-ray, normal ECG, parents still requesting reassurance from specialists, then they're like, oh, I know exactly what I need to do. That's all. When you're starting to look at, let's start with the electric. So remember the heart has plumbing and electric. We'll start as electricians. So any of the dysrhythmias. Pretty uncommon in pediatrics. If there is, it's likely secondary to something else. They're very rare primary rhythm issues. Do they happen? Absolutely. But most of the time, the electricity has gotten off because of some infection, some inflammation, something was formed abnormally, so now the electricity is abnormal, or something with the metabolites is off, so your or electrolytes. Otherwise, there's a bunch of normal variants. So those things we'll look at can be normal for kids. The first one, that's technically a dysrhythmia, is a sinus arrhythmia. This is just when they're breathing. Inhale, your heart rate increases. You exhale, your heart rate decreases. So at all times, you see a lot more variation with children though. So whereas adults, you might not see all that much variation with breathing, with children, you can see a substantial variation in that. No eval, no treatment, because again, this is just physiology, totally normal. The atrial dysrhythmias, what I need you to write in here somewhere is just neonate, newborn. This is the things that typically are going to see while they're in the neonatal ICU. So probably, unless you're in a NICU and you're in forging away in the military as a NICU PA, I hope some of you do that, probably not going to see this very often. Typically when an infant is premature, you're going to see these abnormal P waves, so this kind of wandering atrial pacemaker, where it's got normal QRS complexes, but the P waves will have different intervals and they will look different. So again, normal for the neonates. Same thing for the premature atrial contractions. They are normal in the newborn period of time. And you'll see these without changes in the QRS complex as well. So pretty benign, most of the time they'll disappear. If you're seeing atrial flutter or atrial fibrillation, very, very uncommon and is typically after they've had heart surgery. So that is really a secondary effect from having their heart manipulated with. Remember, if you're thinking about, okay, if we're doing pediatric surgery, think about the size of a pediatric heart. It's about the size of a small strawberry. Right? That's how small these hearts are. So when we're talking about conduction defects of a strawberry, right? And when we're talking about some of these anatomic variations, it's of a strawberry. So pictures of what that wandering pacemaker looks like, just seeing different morphologies of those P waves followed by a normal QRS. And then your premature atrial contractions, you just got another one thrown in there. Everything else is continually normal. And then remember, flutter and fibrillation, pretty uncommon, typically after surgery. star, underline, highlight this one, you're going to need to know SVT, because if they're going to have a dysrhythmia for kids that is going to affect you in clinic, in the ER, in the urgent care setting, it's going to be SVT. So can be in the neonates, can be in young kids, can be in older kids. So we had a girl in our pediatric clinic who she kept coming in, and she was a swimmer, and she was like, I just get up, and sometimes for practice or if I'm thinking about swimming, and I just feel like my heart is racing. And she saw a couple of different providers, and it was like, oh, you're just anxious. You're anxious about swimming. You're just anxious. And so she ended up being put on an SSRI, and the whole time the girl had SVT, and she was having intermittent runs of palpitations, right? What does an SSRI do for SVT? Nada, right? So we weren't helping her at all. We were missing SVT. So listen to your patients in full evaluation. But SVT, common symptomatically for a child or a baby with a dysrhythmia. A lot of it, higher heart rate than the adult. So if you're thinking the adult tachycardia was in the 160s, 180s. For tachycardia of an infant, we're talking 220 up to even 300. You're thinking 300 beats a minute? That's insanity, right? You know that heart is not relaxing at all, which means what is not getting perfused? Anything, but particularly what? What gets relaxed, or what gets perfused of the heart during relaxation?
The heart.
The hearts of the coronaries get perfused during relaxation. So if the heart is beating that fast and it cannot relax, you know the coronaries aren't getting perfused. You know that heart is not going to hang on forever for that. Usually a normal structurally heart for SVT, and eventually if this hangs out for so long, for several hours, then you are at risk, and this patient is at risk of coding, because their heart can only keep up for so long with that without being perfused. Okay, so your biggest thing here is going to be deciding, are you stable, are you unstable? So a stable baby or a stable pediatric patient is still communicating with you potentially. Their pulses are maybe still present. Their skin color hasn't changed. Right? If you start seeing an unstable patient, they have thready, deep pulses. They're cyanotic. They're hypoxic. They're not. They're altered. They're not with you anymore. Right? So being able to recognize stable or unstable. And then how are you going to treat them? If they're stable, you're trying vagal maneuvers first. How do you get a newborn baby to do a vagal maneuver? Kind of a trick question, right? You are holding them, but how are you holding them?
Nose closed.
Upside down.
Oh.
Hold the baby upside down. We had this one attending, it was great. Like, if the baby was in SVT, he would just come over to the bassinet, hold him upside down. He'd be like, get an ice bag. And you just hold him, right? So it's going to help put that pressure, that Valsalva on a baby. Or an older kid who's still with you can do the typical hold your nose, or blow through a straw, or we had pinwheels where they would say, can you blow the pinwheel to get them to move? So different things like that. Okay, then when I say ice to the face, do the diving reflex, what do I mean? Ice to the face? That's exactly it, right? So the first time I did it, I went and got some ice, and I put ice and I put it nicely next to the face. That was wrong, right? You have to do it as though they are jumping into cold water. So it feels really wrong, but you're taking a bag of ice and you're smothering the baby with your ice. That is functionally what you're doing, because you're inducing that diving reflex of, oh my gosh, I'm really cold, to immediately slow the heart rate. So you're like, so to get this straight, I hold the baby upside down and then I smother it with ice. You're like, yes, you've got it. Right? That's what you're doing for the first part of vagal maneuvers and ice to the face. Okay, if that fails, which it probably will if they're in SVT for that long and they're that symptomatic, or they're unstable, the next thing, you're going to that adenosine. What do we know about adenosine? How does it work? You gotta go, you push it really fast, right? So what happens when you have a teeny tiny little baby and it's a teeny tiny amount that you're pushing? You gotta do a couple of things. One, if you have a long line of tubing and you push really fast, you're like, I just pushed it into the tube. So sometimes you're connecting it directly to the IV or the IO. So you're trying to get it as close as you can. And then you follow it with what? With a saline flush. And sometimes you're going to use a little bit more than you would think because you've got to get it to the heart. Then what happens? What happens because of the adenosine? It just stops. Remember what that half-life is? 6 to 8 seconds. So you just sit there and you're like, oh my God, please restart, right? So long 6 to 8 seconds, and then that heart rate's going to pick back up. If you can't get an IV, what are you going to do? You're going to get an IO, okay? If you can't get that, or if someone's trying to get that and they're still unstable, that's when you start doing cardioversion, synchronized cardioversion. I caution you, it is in the guidelines and you should do that. If you don't have an IV or an IO and you cardiovert an unstable patient, they will code on you and you will be doing that IO ASAP then, so just go ahead and get the IO. If you can't get the IV, you'll need it when they move. SPC, if you're looking at this is between what? Just like 200, 250 beats, 300 a minute. Very, very, very fast. Other things that we think about, other dysrhythmias. So you have ventricular PVCs. We see PVCs all the time in adolescents. Why? Because most adolescents have an unhealthy or a healthy heart.
Healthy?
A very healthy heart, right? So if you have a very healthy heart and you are a developing adolescent, is your heart rate pretty high or pretty low?
Low.
Pretty low, right? Or you're a marathon runner, or you exercise a whole lot. Low heart rate. Eventually, you get so low that what happens?
You look bradycardic at rest.
Yeah, you look bradycardic at rest, and your SA node is like, wait, are we going, or does the junctional node need to take over? And that junctional node takes over, and all of a sudden, you have a PVC. So a lot of teenagers will have a significant amount of PVCs because they actually have really healthy hearts. It's benign for most of them. If you associate it with, if they're passing out or fainting, that's one of your red flag symptoms, and so that is not normal, not okay. And then if you have ETAC, ventricular tachycardia, certainly if you have more than 3 in a row, very, very rare, that is a very serious, that is something you can shock. You should start coding the patient. So PVC is completely normal until you have a run of them. PVC is totally normal. VTAC, totally not normal. VFib, get the AED. As a reminder for your heart blocks, you're that first degree. So first degree is just that prolonged PR interval. It is normal that you see. No other evaluation or treatment is going to be needed. Your type 2, again, these are very, very rare, so we don't spend a whole lot of time with them. But if you're looking at Mobitz type 1, it's going, going, gone. So it's starting to get longer, longer, and drop. Going, going, gone. Versus your type 2, where it's all the same and then it just drops. So it's, the way I learned it was duck, duck, goose. So duck, duck, drop a goose. So it was going, going, gone, or duck, duck, drop a goose. And then your third degree heart blocks, the top ain't talking to the bottom. So your atria and your ventricles are totally separate. Nothing is communicating at all. These are the ones that you need to get someone ASAP because that is a medical emergency. Heart blocks, again, very rare. Don't see them often in children. Much more likely they're going to show up on your pants in the adult section. The one that does come up is your congenital complete heart block. So when mom is pregnant and she has autoimmune disease, so typically you see it with lupus is the most common one. You can also see it with Sjogren's syndrome. But mom will make autoantibodies against those. Those antibodies can cross the placenta, go into baby's circulation, and it looks at the baby and it looks for those heart receptors. And it thinks that those autoantibodies from mom actually need to go attack the heart. And so it will attack the septum in the baby's heart, and the baby will be born with a complete congenital heart block because mom's antibodies went and attacked baby's heart. Okay? I've seen that on the boards come up all the time. You're like, why is this baby born with a congenital heart block? You're like, mom's lupus. That's the reason. Mom's autoantibodies. That baby gets put in the NICU right away. That baby goes in for surgery to get a pacemaker right away. Which takes us to congenital heart disease. This is my favorite part. So I don't really love the electric side. Some people love the electrician part of it. I really like the plumbing side of it. So when the anatomy doesn't form correctly, we end up in these labels, okay? So congenital cardiac babies, we split them into two categories, acyanotic and cyanotic. What color are the acyanotic babies?
Pink.
The pink babies. What color are the cyanotic babies?
Smurfs.
The blue babies. Okay, so the first thing I need you to do when you're studying this, is this a pink baby or is this a blue baby? Okay, so we're going to start with the pink babies. So this would imply that everything is either has no shunt or it's shunting from left side back to the right side. So we have already gotten oxygenated and we are going back to get oxygenated a second time. So these ones have a lot of that over circulation issue, but the baby's pink. Pink babies for this one. We're going to talk about all of these, but just in general, okay, so let's say you're run of the mill, you're working in the delivery room. How many babies need some sort of help with breathing? They need some sort of resuscitation. What percent of babies? 10% of babies, correct. So 10% of babies need some sort of help. Out of all of those babies, what percent of the 10% need advanced cardiac help because they have congenital cardiac?
10.
1% of all babies. So 10% of the 10%. Right? 1% of babies have some sort of cardiac defect. 1 out of 100. Of that 1 out of 100, a quarter of them are going to have VSDs. So if you have to pick something on your pants, you're like, just sheer number, by sheer epidemiologic statistics, it's going to be a VSD. So that would be your takeaway. You have to pick VSD is the most common. There it is, most common. So you're thinking, okay, well how big does the VSD need to be? Again, we're talking about a strawberry. So the size of this strawberry means that it doesn't take a whole lot to go from asymptomatic to symptomatic. So 3 millimeters, I looked this up this morning, 3 millimeters is the size of 2 stacked pennies. That's not very much. To go from asymptomatic to now 3 stacked pennies, we have CHF and failure to thrive, right? That distance ain't a whole lot, or 3 to 4 stacked pennies, right? That's not a whole lot. So you can go from I'm totally asymptomatic because I have a small defect to I have congestive heart failure and I'm really struggling. It's not a whole lot of difference there. These murmurs are going to sound harsh. We already said harsh is bad, that's pathologic. And pansystolic, all of systole, because as that heart is squeezing on the left side, all of systole, blood is going from that left ventricle back to the right ventricle. All of systole, that left lower sternal border, right where that septum is. The small ones, most of the time, are going to have normal studies. On X-ray, you might see the heart's a little bit enlarged, and you're going to see this CHF because it's over circulating. So the got circulated through the lungs, went to the left, gets pushed right back over to the right side, and the lungs are like, man, I just circulated you. And so that's where you get that over circulation pattern. Left ventricular hypertrophy happens then because it's having to push harder to overcome to make sure enough gets out the aorta. So you end up having to squeeze harder to get enough to the body as you lose some to that right ventricle. That's why you see that left ventricular hypertrophy. Over to cardio, and they will help decide what we are going to do. There's two parts of the septum. So the middle of the heart, there's a muscular part, embryologically, and there's a membranous part. If they have a small membranous defect, the body can figure out how to grow a new membrane. So a third of those will just close on their own. You're like, really? The child just grows a new membrane and fixes the hole in his heart? Yep. Kids are amazing. The other ones, particularly the muscular defects, a little bit farther down in the septum, those don't close on their own. So as they're getting moderately larger in size, we're having to help them with that overloaded chest and that afterload reduction. And then eventually, and this is going to be a rate limiting step for a lot of things, eventually that pulmonary vasculature says, I'm done with you. I've already circulated it once. I'm done doing it again, and I'm going to get pulmonary hypertension to close this off. And when I close this off, then you're going to see increased pressures. You're going to see nothing's getting oxygenated, and eventually then you're going to have to close that VSD to allow that normal circulation to continue. So you're trying to balance. I don't want to put the child under cardiac surgery. I don't want to give them anesthesia too early to this young developing brain, and I also need to manage their heart and any kind of heart failure. So we're trying to balance that. So when you're starting to see they're not growing or there's significant pulmonary hypertension, those are kind of your rate limiting steps. Okay, what about the atrium? So we talked about the atrium, or the ventricles. Now we're going back up. So we said everybody has a foramen ovale. It's only when it stays open that you then have a PFO. So that's a normal hole that stayed open abnormally. An ASD, atrial septum defect, is a totally different spot in the atrium septum wall. It's a totally separate hole, and it's usually bigger. And so ASDs and PFOs, not the same thing. Okay? You can't tell that. It's going to take cardiology and an echocardiogram to tell you the size and where it is on the septum to help distinguish if it's a PFO versus an ASD. So don't spend time trying to learn and distinguish that. Somebody on the pants or somebody in a test question will tell you that. Pretty much not symptomatic early. As it gets, if it gets bigger or it's persistent, they can get symptomatic later on. So you see this as a problem as kids get older. So this is typically something you see while they're in school-age children or right before adolescence. The thing that you will see is that fixed split S2. So remember which valves are closing with S2? Pulmonic and aortic, right? So when you have a fixed split S2, the aorta closes and the pulmonary then takes a minute. The way I always thought about it is, okay, let's get as much blood as we can in there before we shut. And so instead of them going together, you have 1 and then 2. 1 and then 2. And if it stays that way and doesn't change with your breath, with anything else, it can be an ASD. Nothing else does that besides an ASD that predictably sends the same amount of blood back to the right atrium every single time. So if you see fixed split S2, has to be an ASD, and be nothing else. Your chest x-ray, you probably won't see anything at first. Over time, because that right atrium is taking so much more blood, it's going to start expanding, or take us all up with some automated thing there. You will see some right axis deviation, again because left to right, acyanotic, pink baby. It's going to that right side and it's filling the right ventricle twice. And then echo will tell you what it is. Again, this can often spontaneously close. So again, you're like, they can really just fill in that septum. Yep, sure can. So a lot of times they will close spontaneously. If it is significant and they are above toddler age, they're talking to you, they're about to go to school, or if they're older kids and they're starting to become asymptomatic or symptomatic as time progresses in late elementary school and middle school, that's when you start thinking, I need to close this. So they will sometimes do a catheter closure. Rarely do they have to open the chest up, but that would be your secondary thing you did too. We already talked about your ductus arteriosus. If it stays open inappropriately, now you have a PDA. So way back from block 2, what disease was associated with a PDA? Congenital rubella, correct. So congenital rubella has that PDA down the books. So thinking about the reason that, again, it's going to overcirculate, so you see CHF again. The things that you see with the two things, those buzzwords, widened pulse pressure, well, this makes sense because you're having to put more pressure out to supply your whole body. So your high pressure is going to be higher. Then you get a lot of that runoff, and so your low pressure is lower. So widened pulse pressure is thing 1. Thing 2, the continuous machine-like murmur that you always hear. Why is it continuous? What causes the sound to make it start and stop?
Opening and
The closure of the valves. Are there any valves in the ductus arteriosus?
No.
No, there's no valves, so there's nothing to start and stop it. So it's just continuous. So the only thing that's continuous has to be outside of the heart. The only thing that you can see outside of the heart is going to be the PK for continuous murmur. Here in the infraclavicular area, right where it is connecting, that should make sense for that one. Your small ones, they're going to all have normal studies. The little bit larger ones are going to see on chest x-ray. Again, kind of that overfilling of your pulmonary vasculature as things go backwards. You might see that pulmonary hypertension as things overcirculate again. And then the treatment that you guys learned is a little bit misleading. So NSAIDs will close this. So we give IV NSAIDs with indomethacin, but really that only works in the neonate period. So we only do that in the first couple of weeks of life when they're responsive to that. It's still a hit on their kidneys, so you're like, wait a second, I can't give a baby ibuprofen, but I can give them IV NSAIDs. You're like, well, yes, there's a risk-benefit calculation, and in this, the benefit of having a closed PDA without surgery overrides the risk that their kidneys will take. After that, it becomes a coil embolization to go in and close that. Rarely an open procedure, sometimes they will go in and they will do a clip on it. So then you end up with that PDA. A couple of other ones with the stenosis. So any of the valves can stenose down. So you can stenose under the valve, at the valve, or above the valve. So subvalvular, valvular, or supravalvular. You can do that. Anytime that's the case and the valve isn't moving well and it's really stenotic to open, it makes sense that you're going to have dyspnea and fatigue because you're not moving blood effectively. So that should make sense. As it opens up, you're going to get those clicks. Those clicks, you know you have something valvular with that. And then depending on where it is, it's going to radiate. So the one thing that, at least on my boards, it might not be on yours, but it was supravalvular aortic stenosis. You see supravalvular aortic stenosis, it goes with one genetic disease that you guys learned from block 1. They had Ulfian-like personalities, and they had high calcium. What was that? Yes.
It's like a person's name.
Williams syndrome, correct. Exactly, Williams syndrome has supravalvular aortic stenosis at high calcium. I don't know if that's the pathophysiology, but it always made sense in my head. You have a lot of calcium can go on the valve and make them stenotic. If that's not the pathology, at least I remembered it, so maybe you will too. Again, your EKG and chest x-ray are going to be normal because the electricity is still normal of that. This is plumbing. Depending on where it's back flowing is then where you get that ventricular hypertrophy. So that should make sense with that. They go in for treatment and they do a balloon valvuloplasty where they then just they are able to open up those valves. And both of the prognosis for the aortic stenosis and the pulmonic stenosis are very, very good. So good prognosis with that. Aortic is even more so than pulmonic. So really good prognosis for those. Co-work, Tell me what you know about co-arc. What are the
Different pulses between the arms.
different pulses between what?
Left and the right.
Top and bottom. Which one's higher?
The top and bottom.
The top? Okay. What about the color of the skin, top to bottom?
Yeah, for some reason I thought it was
Red.
green.
Blue, white, I know it, yep.
Just kidding.
What else about this one that you can test?
I think a second.
Outside of that, keep the ductus open. You guys have that femoral pulse is weaker. Yeah, there's like 3 ways to test this question, so you guys have all the ways. They will have to give you something top to bottom, a difference in pressure, a difference in skin. What does it look like on chest x-ray if they've had long-standing co-arc? What has happened to get blood to that lower extremity? Rib notching tells you that they've developed what? Collaterals. Yep, so they've developed these collateral blood vessels that are going right under the ribs to try to find room to exist where they really shouldn't exist. Got that. So right where that narrowed part and that co-arc is, they'll go out, cut that out. Your x-ray, they're going to have the rib notching, that big aortic part. Rib notching tells you it's been there a long time, so it's not just something that they're like, oh, they're a 3-day-old infant, they have co-arc, they have rib notching. Rib notching tells you they've had enough time to make collaterals and they're a significant amount of time. For treatment-wise, there will be something on your test and there will be something on your boards that is trying to get you mixed up between when do you give indomethacin and when do you give prostaglandin. So prostaglandin props, remember? Prostaglandin props things open, so it's going to keep everything open. This is going to keep your ductus arteriosus open. Okay? Prostaglandin can also be called PGE, can also be called alloprostadil, alloprostol, a lot of different names that have prost in them. The thing about this is you have to give prostaglandin as a continuous IV infusion. So it's not something you give outpatient. And in fact, one of the side effects of prostaglandins for a baby is apnea. So if you are giving PGE, you need to have airway control of this baby, and they need to be in the neonatal ICU or the PICU because they are intubated and sedated until such time they can get to that surgical repair. So anytime you're picking PGE, just know that that comes with a lot of other things clinically. When we start the cyanotic lesions, we're just going to barely touch on this, and we'll end a little bit early, but cyanotic lesions indicates, again, that you are a blue baby, and that blood is going from right to left and bypassing your lungs. So it didn't get oxygenated. That is why you are blue. I don't know if Dr. DeBoer taught you the hand model. Did he teach you the hand model? Did I teach you the hand model? I was like, I did. Okay.
In the lab.
Oh yeah. I was like, I feel like I've done this. Great. So the one big trunk, truncus arteriosus. One big trunk. The 2, where you have 2 blood vessels, transposition of the great vessels, the aorta and the pulmonary vasculature. 3, tricuspid atresia. You don't have that. 4, tetralogy of Fallot. 4 components of that. And 5, my favorite one, total anomalous pulmonary venous return. Just 5 letters. TAPDO. Absolute favorite one. Then hypoplastic left heart, sagittal heart, and I have nothing for Epstein's anomaly. So if anyone has something to add for the E, I would love that because I don't have anything. All of these, if you're blue, well, anything in this lecture goes for any of the cyanotic or acyanotic, they go to cardiology. Especially if you're blue, you need both cardiology and your cardiothoracic surgery. So you're going to need both of those because those are both going to have surgical interventions. If I stop here, are you guys going to be mad? Or this is just like a big topic, so I'm like, rather than in the middle, we call it here and we pick up on Friday. So I need 2 things.
We'll
your
forgive you.
homework. Number 1 from neuro was what? Check your armpits. 2, I want you guys to know the hand ones and be able to spout those off for Friday so that we pick up.